Dr. John Bennett, broadcasting from Miami. We have tonight the pleasure of having Jerome Lisk, MD, a board-certified neurologist and a movement disorder specialist, who tonight's going to talk about restless leg syndrome. And we have a couple of distinguished panelists. First, we'll introduce them, and then we'll turn it over to Jerome. Good evening, Mohammed.
Good evening, Dr. Bennett. It's a pleasure to be with you tonight, and thank you for inviting me.
And you're in Toronto, correct, Mohammed?
Yes, I'm today come from Toronto, Canada.
Welcome, Mohammed. And then?
Hi, everyone. I'm Dr. Mulpuri. I'm Van Mulpuri from Michigan. I'm an internal medicine physician, and I'm very much excited to learn more about these movement disorders, and I'm glad to be here with you guys.
Very good. Welcome, Ben. Yep. Okay, Jerome, I guess you're going to talk about restless leg syndrome. Take it away, and then we'll ask some questions after you're done.
Okay, so restless legs is a disorder of the dopaminergic system, and it involves irresistible overwhelming feeling to move your legs. Usually happens at nighttime before people go to bed, or when they're going to bed. And there's something called periodic limb movements of sleep, and these are both different. So the difference that separates periodic limb movements of sleep and restless legs is this irresistible feeling or sensation to move your legs. Now, when patients come into the clinic, everyone has a different description of this. And some patients will call it an electric type feeling. Some people will call it spasms, burning, itchy, crawly, shocks. There's a wide variety, such a variety that in the speaker slides that we do for different companies, there'll literally be 30 or 40 different, descriptive terms there. So the bottom line is it's an uncomfortable, unpleasant feeling that makes you want to move your legs. And when you exercise your legs, massage them or exercise them, move them, that feeling improves or goes away. So there's certain dopamine agonists, there's medications to treat this. There are medications that are usually the first line are dopamine agonists. They don't have to be the first line, however. You could have medications such as gabapentin. There's a medication called Horizont, which is extended release gabapentin. There's also a medication called Requip, which is the class of dopamine agonists. Then you have Mirapex. Requip and Mirapex both have long-acting forms, Mirapex ER and also Requip XL. And then you have Nupro, which Nupro is a patch, and it comes in 2, 4, 6, and 8, 2, 3, 4, 6, and 8 milligram patches. And the dose for restless legs is usually about 1 to 2 milligrams, and that is one of the truly 24-hour drugs. Also, Cinemet can be used, carbidopa, levodopa, and also you can use tramadol. Now, there's two things that we have to worry about with restless legs. First of all, we don't want something called augmentation. And what augmentation is when you give a medication that augments the restless legs. It causes the symptoms to occur earlier and earlier in the day. They start creeping earlier and earlier in the day during the day. So first it's happening at dinner, then it's happening at 3 o'clock, then 12 o'clock, then in the morning. So the treatment for this is usually happens with either Cinemet, which is the highest rate of augmentation, or a dopamine agonist. And the classes of dopamine agonists again are Requip, ropinirole, which is Requip, pramipexole, which is Mirapex, rotigotine, which is Nupro. So we have to immediately stop one of those drugs if patient's on that drug and switch them to alternate therapy. Otherwise, your patient's going to be miserable and waking up with restless legs. Restless legs could also go to the arms. And I think before we knew it could go to the arms, we'd already named it restless legs. So, we haven't reclassified it at that time. But you can get people that have symptoms in the arms. Now, severe restless legs could also be treated with IV iron infusions. I'm a member of the International Restless Leg Study Group, and there are patients that receive iron infusions as well. Now, when you see a person with restless legs and you first take the history, it's important to also see if they have a neuropathy, because a peripheral neuropathy is damage to the nerves in the legs that cause numbness or pain in the legs. And diseases such as diabetes could cause a peripheral neuropathy. So certain things that could cause restless legs: peripheral neuropathy, severe lumbar stenosis, uremia. Patients on dialysis are more prone to get restless legs as well. Iron deficiency, anemia, could also cause restless legs. Also, peripheral vascular disease could cause restless legs as well. The nerves aren't getting blood, the nerves are being injured, okay, thus causing kind of a neuropathy in the legs. So if a patient comes in with diabetes and they have an undiagnosed neuropathy, it's important to do peripheral testing with a pinprick up the leg, and to also test vibration and proprioception in the leg, in the toes. When you test that, you may actually then diagnose the patient with a neuropathy, and then a dopamine agonist may not be the best therapy. Something like gabapentin may be the best therapy. So once you figure out any other comorbid factors, then you want to also do laboratory testing. So the biggest thing we test for right now is a serum ferritin. If the serum ferritin is below 50-55, we do supplement with iron. Now, there are some recommendations to, if the patient serum ferritin is lower than 50 or 55, to get that iron level above 70, so that you're really giving the patient a buffer. Because iron deficiency and a low serum ferritin will make the restless legs worse. So that's the.
It's frozen.
Okay, we'll just wait a second. Okay, have you guys ever seen restless leg while we're waiting for Jerome to unfreeze?
Yeah, I had a actually personal experience with restless leg syndrome, and I have like very few questions for Dr. Lisk.
Oh, okay. Well, we'll just wait a second. He'll unfreeze in a second, hopefully. But you actually have seen it, huh? How was it treated?
Yeah.
Do you remember, Mohammed?
They gave actually Toradol was one, and Ramiprexol the second. Ramiprexol was #1 drug they gave it, and we tried the patch. The patch didn't help. I mean,
Okay.
they say this patch, nitro patch. A lot of drug companies are advertising for it, giving a free sample. Just try it.
Really,
And we
nitro
tried
patch,
it.
the same nitro patch for cardiac problems?
No, it's different. It just
Different
has,
nitro patch?
yeah. Let me tell you what exactly it has in.
I'll be right back. In the meantime, Dr. Lisk, maybe.
Well, you know, the Toradol, that's an injection. You mean Toradol
Right.
injection, correct?
Right.
Okay. There you go, Dr. Lisk. You're on now.
Here I am.
Okay. Might as well
So-
continue.
So where did I leave off?
Okay, gentlemen.
The
You left
area
off-
where we have two screens here. Okay, the area where you left off was, let's see here. Let's see exactly where.
The changes in like diabetics, how different groups
We
can
covered
get
that part.
restless leg syndrome.
Peripheral
So-
artery disease, vascular disease, and restless.
Okay, so the next thing is that we want to test for a serum. When you go to laboratory testing, we're testing for a serum ferritin. Because the serum ferritin, if it's lower than 50 or 55, the restless legs can be worse. So we're going to get that serum ferritin usually above 70. Once it's above 70, you can actually stop treating. You give ferrous sulfate, 325 milligrams 3 times a day. Now, one of the medications called tramadol that I mentioned, tramadol is used for augmentation, usually. Sometimes you'll see patients using tramadol. You'll see patients using tramadol on a regular basis, but primarily we use it for augmentation. Another medication that's used for severe restless legs before you would give someone iron transfusions is methadone or narcotics. Narcotics work fabulous for restless legs, you know, but most doctors will use methadone instead of using narcotics, and methadone works fabulous. So that's kind of I think I was talking about rebound, where rebound is where you take the medication at bedtime, the restless legs gets better and goes away, so the patient can sleep, and then the patient wakes up with restless legs about 1 or 2 o'clock in the morning, or maybe 3 o'clock in the morning because the medication is worn off. So rebound happens with more short-acting medications when that medication is worn off. So the way you treat rebound is you switch to a longer-acting medication. And like I said, when you look at the medications, Mirapex ER and Requip XL are about 18-20 hours, somewhere around there, maybe 22 hours. They're not truly 24 hours. The only one that's truly 24 hours is going to be Nupro patch, okay? And that's going to be the one that truly lasts that long. Another thing is if you're having rebounds, sometimes giving the patient if you have a longer acting medication, sometimes it's better to give it at dinner because the longer acting medication may take a while to kick in, whereas Nupro takes about 2 or 3 hours to get to steady state. Another medication called Retari has just come out. That's for Parkinson's disease, but since it's carbidopa-levodopa, we may be using different formulations of levodopa, such as Cinemet CR, Retari, which is the first extended release Cinemet. We may also in the future start using Neuroderm, which is a Cinemet patch that may be coming out soon. And I haven't seen patients use I haven't seen anyone use apomorphine yet, but that would be interesting to see if that works. I haven't seen any data on that yet. So,
do you mind if we ask a couple questions?
Sure.
Okay, why don't you go ahead and first, Mohammed, you have a couple.
Okay, so first, thank you so much, Dr. Lisk, for this interesting information about restless leg syndrome. The first question I have is, you talked about having some symptoms in the arms. Like, what would they complain of? Is it like numbness? Is it itchiness? Or
usually it's the same symptoms they have in the legs, but milder. And some of them will say, okay, I have a internal feeling of restlessness in my arms, or sometimes they have sensory complaints. If they say they have burning or aching in their legs, usually they're having the same type of symptoms in their upper extremities.
Okay.
Just not as severe because it started in the legs first.
Okay. The second question is, there's one case I saw where there was restless leg syndrome and polycythemia vera. So what kind of medication would be best for this, do you think, in your opinion?
I think any of the medications, because none of them, usually I try to pick a medication that's going to treat something else. So gabapentin treats neuropathy. So if the patient has neuropathy, well, then I'm going to use gabapentin or Horizon. If the patient has depression, well, I may just use Mirapex because in some studies Mirapex has been used as an adjunctive has an antidepressant, very mild, weak antidepressant qualities. So in this situation, you would probably just want to use something. I usually start with either gabapentin or dopamine agonist.
Okay.
Because levodopa has the highest rate of augmentation. Mm-hmm. And so we typically don't try to use levodopa first or second line.
Okay. And for the Nupro patch, any patients you cannot use Nupro patch? Is there?
No, you don't have to. That's a good question because you don't have to adjust it for hepatic or renal impairment. You cannot use a Nupro patch in patients that have a sulfite allergy. And some people that have asthma have sulfite allergies, or people that may be allergic to red wine for some reason. So sulfite allergies is a contraindication to Nupro.
Okay. Well, thank you so much.
Yeah, thanks, Dr. Lisk, for an extent. You just arranged this conference today. You just called me. But you know, Dr. Lisk, does it ever occur alone, or is it usually associated with diabetes? Or something?
A lot of times it occurs alone. You know, it could happen coexisting with Parkinson's disease. There doesn't seem to be a higher frequency of having Parkinson's disease versus restless legs, independently or together. So usually you see it happening independently. There doesn't appear to be any, risk factors that predispose people, such as age, like with Parkinson's disease. This doesn't seem to do it.
I get the impression it's not a constant thing. It kind of has flare-ups.
You know, sometimes it can happen consistently, and sometimes sometimes it can happen once or twice a month. It's such a different frequency for everyone, so everyone's different. The people that we see in the clinic, of course, are those people what's happening every day. Those people that happen once a month are probably not going to the doctor.
Right.
Okay.
It's like a central tremor. People with the central tremor don't go to the doctor until it starts interfering with their function.
Right.
Right.
So until it starts really significantly interfering with someone's sleep, they won't go to the doctor at all. They'll have it for 10 years, and you'll be the first doctor they see.
Wow. You know, I guess you don't want to use narcotics chronically, of course, but it's very effective in a flare-up, you say, of a bad flare-up of restless leg?
Oh, yeah. Yeah. I prescribed Norco or Vicodin in the past when I've had a patient. I pick my patients carefully, make sure there's not going to be any type of, make sure this is not a patient that may any history of substance abuse. This may be a patient that I may be suspicious that may, you know, abuse the drug. However, abuse of narcotics has no face, no look.
Right.
And so going to something like methadone is safer, but that's just for severe restless legs. You've already been through a dopamine agonist. You've already tried an extended release dopamine agonist. You have to be careful with Requip and Mirapex because Requip's metabolized by the liver. So if they have a cirrhosis of the liver, I'm using Mirapex. In Mirapex in the package insert, or what Mirapex also called generic name is called Pramipixole. There's no data in dialysis patients, and those patients with a creatinine clearance less than 30, there's no data. So you're basically, you know, there's some medical legal risk there, and you're basically out on a limb. So people with renal impairment with a creatinine clearance less than 30 are on dialysis. I'll use a different drug such as gabapentin, Requip, levodopa, or Nupro, or Horizon. Horizon is a great drug too.
Are there actually any histological changes in the nerve? Has that been studied at all in restless leg syndrome? Are they figured out exactly?
That's a great question. I don't know the histochemistry or any histopathology of the of nerve biopsies with restless legs. Yeah. But I'll definitely look that up and get back to you on that. That's a great question.
Okay, thank you.
It's not something that's being. I just was at the Movement Disorder Conference in San Diego, it's an international conference, and I heard nothing about that in the conference, and I've heard nothing about that ever. So I would assume no.
Okay.
There's probably normal nerves.
Yeah, it was pretty.
Just like when you have Parkinson's, problem with dopamine regulation, you know, you have loss of dopaminergic nerves, but the nerves themselves are probably, there's nothing probably histologically wrong with them.
Do you have a lot of patients in your practice with restless leg?
Yes, I do. I'd like to see a lot more, but a lot of the primary care doctors will see these patients and treat them, and they'll start them on a dopamine agonist right away. Primary care doctors are very good at starting people on therapy, and the majority of the people get started on a initial therapy. They're pretty good. They respond pretty well.
What's happening, Dr. Lisk, is we're seeing a lot of patients. I mean, I did a lot of primary care rotations. We're seeing a lot of patients. It works first, and then all of a sudden, they're having like this rebound, like you said. They're waking up 2 a.m. They're having this severe pain, and then they take like additional medication, like Toradol or other medication, just to calm them down. But yeah, I think it's important to get them to movement disorder specialists, like to know the exact augmentation.
Yeah. You know, the two things we worry about: augmentation and rebound. Augmentation's worse than rebound, in my opinion, because the drug, usually the primary care doctors leave them on the drug, and they just keep on getting worse and worse and worse and more miserable. And now it's like, now they're not having it at bedtime, they're having it at dinner. Now that they have it at dinner, they're having it at lunch. Then they're having it at breakfast. You know, and because they don't know about augmentation, they just don't know what to do. And they say, well, the patient responded before, you know, I don't know what's going on. And once the patient comes to me with augmentation, I can't get rid of the augmentation. I just have to treat them. Augmentation is going to stay. Like once you take them off the drug, the augmentation doesn't go away.
these patients must go through a period of misdiagnosis. They must. I know that I probably wouldn't recognize it if I saw it because I've never seen it myself. I have a background in emergency medicine, but do you see a lot of that? Patients come to you after seeing doctors for years and they're not really diagnosed?
Not as much as other diseases. Usually the primary care doctors will diagnose it. I think physicians of all specialties are pretty savvy in diagnosing it now. When you have periodic limb movements of sleep, it's where the legs will twitch in their sleep, but doesn't stop the patient from going to sleep or anything like that. Okay. But if the patient's walking up and down the driveway at 2 o'clock in the morning because their legs are uncomfortable, most doctors are going to get restless legs. So not a lot of misdiagnosis. There's not a lot to misdiagnose, really.
Right. That's an unusual thing.
My legs are killing me and I can't get to sleep, and it only happens at night.
Right.
Not a lot of things can do that.
And you've seen a lot of doctors that are comfortable treating it before referring to a neurologist?
Yeah. I see, there's a lot of primary care doctors that have success. But I think, education-wise, we need to get out to people through through this neurology web TV, through what you're doing. Patients don't even know to talk to their doctors about it.
Okay.
Just because patients are having it does not mean that they're actually telling their doctors about it.
Right. Well,
that's hear about this through you or other educational means. They say, "Oh, that's what that was. That's what that is. Yeah. Let me tell my doctor. There's actually treatment for that."
Yeah.
Well, I got the impression when I had all the hangouts with Dr. Rana. We've had about 60 hangouts, and I was impressed with how much the neurologist has to examine the patient. Not only take a history, first of all, a complete history, as well as do a complete physical exam. Probably more than most areas of medicine. That's the impression I get after having so many hangouts with Dr.
So we can hit the most. We can hit the most when it comes to reimbursement because we have no procedures, so we're billing the same codes as the primary care doctors, and we have to spend more time, which means a primary care doctor can see 30 to 40 patients a day. I can see probably a maximum of 15,
right.
10 to 15 if I want to do a good job.
Right.
If you want to just have a factory and just roll them out, you can see 20, 25 people, but that you're not examining everyone.
Right.
And you're definitely not talking to everyone, and you're not educating the patient.
Yeah.
So we have had a problem with the cognitive specialties getting reimbursed properly. So that's something to think about when choosing a residency.
Yeah, think about that, Muhammad.
You think about that.
Okay.
My best advice is choose a residency that does not have call in the hospital. Dermatology, ophthalmology, radiology, something where they cannot call you into the ER. That's the one you want, and that has a lot of procedure.
Go into ER, just work the shift.
Because ER you have no overhead. Yeah. You're not paying for an office right now. The overhead's killing everyone. So specialties where there's no overhead. You take all that money home. You have to spend it on salaries and all that stuff. So ER is great. They can fly to Texas and do a shift and fly back. I can't go to Texas and set up another practice.
Right.
Because I have my overhead here.
Very good. Well, Jerome, thank you for your first hangout in neurology.
Yeah, thanks a lot.
TV. And hopefully we'll have many more. And I'll just
you may want to edit. You may want to edit that career advice off at the end.
Definitely.
There we go. Yeah, it's going to go viral.
My little rant about me not getting paid in neurology. You may want to cut that off at the end.
No, that's okay. That's all right.
Just go ahead and edit that off.
Okay. All right, Jerome. Thank you very much. Hold on. Don't leave yet. Good night.
Okay.